everything runs within 10 years or 20 years. So as of now, the emergency, as of now, the emergency care in India is very, very less. So with this background, I move on to the objective of the talk, that is to speak about in-hospital and out-hospital emergency victim, how the approach is being given to in-hospital and out-hospital emergency victim in the past, present, and in the future. So in the past, the awareness of emergency was very, very less. The availability of the doctors were very, very less, and availability of emergency physician was questioned. So when this was the situation, the people were approaching the quacks, nearby quacks. They were available 24/7 to the nearby, next to their doorsteps. And of course, the pharmacist, even they are not a trained pharmacist, they are untrained pharmacists and general practitioners were the emergency physician in the past. And because of all these things, the emergency diagnosis was a question mark, and the awareness about golden hour was not at all there. And this resulted in delayed presentation and losing lot of life and lot of missed diagnosis. So, and the ambulances that time are just a transport vehicle only with an oxygen, and the same ambulance would be used for a mortuary van too. So this was the situation in the foreign country. So in India in the past. So having that kind of emergency department, the few scenarios I would like to discuss in the past, how it has happened. If it is a case of myocardial infarction, acute coronary syndrome, the diagnosis were most of the time missed. It has been diagnosed as a musculoskeletal pain or a gastritis or a gas trouble. And most of them have been treated with an analgesics and proton pump inhibitor or a Rantac and antacids. Can you hear, sir?
Yeah, screen is turned off, sir. Please move it, sir.
I didn't get you, sir.
It's not showing screen, sir. Please.
Okay, sir. Okay.
Please share screen again, otherwise.
1 minute. Either Zoom.
You share screen, sir, one more time.
1 minute, sir. What should I do, sir?
Yeah, it's coming.
Share screen. Okay. I'll do that, sir.
Other participant, please mute your mic while Sir is giving session.
Shall I again get connected back, sir?
Yes, sir.
Okay. Same link.
Yes, sir. Same. Yes, you can share, sir.
Yes.
Yeah,
can you see now, sir?
Yeah, it's coming, sir.
Okay.
Okay, it's fine.
So having this scenario, having this kind of emergency room and emergency physician, most of the time the acute coronary syndrome were missed, and they have been treated with some analgesics and antacids. Can you see, sir, now? If it is going to be a stroke, the thrombolysis was not given to anybody in the past. And if it is a trauma, I think the admin can mute everybody's mic other than my mic. When it's a trauma, the golden hour concept is lost, and the spine care was not at all given. The primary care was not there in the pre-hospital setup. And cardiac arrest, most of the time it was used for only declaring and not for any resuscitation. This was the scenario of the outpatient in the past. So what about the outpatient emergency in the present? So in the present, there is moderate awareness about the emergency medicine and emergency care to the outpatient emergencies. And 108 and private ambulance are doing a really good service. Though the service is good, excellent, they come in time and then take the patient to the hospital. The approach what they are giving is a scoop and run approach. They take the patient and go to the hospital, and in between the time, the transit time, the care to the patient is not to the mark. Some care is being given, just an IV rain is started and oxygen is being given, but appropriate care is still a question mark. And the paramedic training is still a question mark because nobody is having 4 years training. The one who is working in the ambulance, they're all short trained paramedic available, and the ambulance is going to the nearest center rather than the right center. And the specialty centers have not been identified by the government. Government did not make any survey related to this. And the pre-hospital information, a patient is coming to the hospital means the ambulance person has to inform the hospitals so that the hospital will be ready to receive the case. So that is not being given. And the awareness of basic life support is still a question mark. And AED in the, of course, it is there in the ambulance. I'm telling you about the common public. Recently, you all know that Mr. Punit, the actor from the Karnataka, who lost his life. So imagine if there is going to be an BLS awareness and an AED available in the gym, his life would have been saved. So the awareness about the basic life support and automated external defibrillator, availability of the automated external defibrillator in the common places are not there. It is now available only in the foreign country, only in the foreign country and the hospitals. In India, common places it is not available. Maybe in the airport it is available, and junction it is, railway station it is available, but it will be very well saved in the cupboard of some railway manager. What I feel, it has to be there in each and every platform, and everybody should be aware about that. And everybody should be aware about how to operate the AED. And the BLS should be the part of the high school teaching. Every year they have to learn college teaching, and this is missing. So presently, these are the problems we are facing. With this, what is the scenario of the same thing in the present? The past we have seen nothing was proper. Presently, what is the problem? So let us say a heart attack. So now the awareness on myocardial infarction is very good. Majority of them are getting transported to the appropriate hospitals because the patient knows. So this is the cardiac problem, this is the cardiac center, that the cardiologist is available there. So majority, I don't say 100%, at least 70 to 80% of people are getting shifted to the right hospital, and the angio, primary care interventions are being taken care. When it's in the stroke, still the question mark, the availability of the cath lab and the neurophysician, intervention neurologist and radiologist is still a question mark. And at least some people are getting the thrombolysis. But the trauma, the awareness is there, or golden hour awareness has come, primary care survey, spine care are being given, but still it is not 100%. But it's a cardiac arrest, at least our people know that we have to initiate CPR. That is there. Paramedic availability is there, but again, defibrillation in the out of hospital is still a question mark. Recently, Karnataka is taking a lead forward, Maharashtra is taking a lead forward. They started with the air ambulance and they reduced the transit time. Patients from one city to other cities can be taken where city there is no availability of advanced cares. The patient can very well be shifted to the area where the advanced care is available. And what you are seeing is Dr. Shalini Nalwat, and she is taking a lead role in this. Hope so in the future, everywhere it will be freely available. I'm unable to give the proper lecture because of crosstalks. Many sounds are unwanted sounds are coming. Cannot mute the other phones.
Unmuted, sir. We have muted them, sir. You can continue, sir.
Thank you, sir. So the air ambulance is being taken off, but maybe in the future it will be very well. So approach to out of, I think the slides are moving, sir. Approach to out hospital emergency medicine in the future, how will it be?
Approach to the out
It's moving, sir.
Yes, sir. The slides are moving, sir.
Thank you.
So CPR वगैरह का सुनते थे ना, तो BLS करके भी basic life support और
the basic life support and the first aid should be mandatory. So what our government should speak, what our teaching institutions should do is they have to make the basic life support and first aid classes as a compulsory mandatory classes in the from the high school, and it can be repeated every year, doesn't matter, because every 2 years we are supposed to renew. And there is no bother, no question about every year they're getting renewed. So I think from the 9th standard, 9th, 10th, 11th, 12th, first year, second year, third year, every part, it should be a mandatory one, and the people should pass. And it should be mandatory for all the teachers. It should be mandatory for all the students. It should be mandatory for all the drivers when they go for driving license. It should be mandatory for the staff of every institution. And even for the public, many places, merchants, everybody, when there are licensing all these, when the essential things are there, it has to be made mandatory. If the proper BLS is known and first aid is known, the outpatient approach to emergency, approach to emergency patient, the outside will be definitely improving, providing we have classes and teaching on BLS and first aid to everybody, irrespective of the year. So this has to be, and every year it has to be recertified. If that is the case, many lives can be saved. And apart from having this, we should have an AED in every floating whenever floating population more than 5,000 a day, say in malls, in theaters, in railway stations, in airport, in bus stand, in big areas where the gatherings happen, in temples, the AED should be made available. So after giving the BLS and first aid class, then we have to plan about keeping the AED. So having these two will save a lot of lives. Suppose the BLS awareness and the AED was available in the gym where Mr. Punit was doing, he wouldn't have been died by this time. He would have been saved. And air ambulances should be made available in the major cities with the trained paramedic and doctors. As I told you in the previous slide, Dr. Shalini Nalwad has taken in the southern part, and it's there already in the north, Maharashtra, they are having it. So hope so in the future years, it will be available freely, maybe another 20 years. When there are a lot of emergency physicians in the country, emergency departments in the country, the need also will improve. Hope so we can have that in the past. And by that time, like a foreign country, we will have a trauma center, burn center, pediatric center, and cardiac center, stroke center, like that. These allocations would have been already made by the government, so that the patient will rightly reach the appropriate center rather than reaching the nearest center and then getting the time wasted. And as I told you before, it is like scoop and run. So later days it will be like a stay and treat and go approaches will come. So the cases like a stroke, the cases like MA, there is no surprise that these patients can get catheterized even in the ambulance. I think it will come over a period, maybe 20 years in future, 2 decades afterwards. There will be a lot of emergency patients, a lot of emergency equipments, emergency facilities will be available. A patient getting stroke will be thrombolized or will be catheterized, intra-arterial thrombolysis will be done within few hours in the periphery. So before even reaching the hospital, it will be done. A patient myocardial infarction also would have been done. So all the interventions, emergency interventions will be carried out on the way to hospital itself. So this will be the future. And tele-emergency medicine will start. When a patient is having a problem, like in foreign country, they are guiding the CPR. They are telling how the CPR should be done to the lay person next to the emergency victim. So like that, in future, tele-emergency medicine will start. The doctors from in-house will be guiding until the ambulance reach how the emergency life support has to be extended. These things will be there in the future. I definitely foresee that, because the way the NMC is taking forward is really good. The one order that every medical college should have an emergency department with all these facilities. That I feel it is a very good start. And with this, the scenario in the future would be, when it is an acute coronary syndrome, majority will get primary coronary interventions. But it's a stroke, majority will get shifted in time for thrombolysis. There will be mobile cath lab, mobile CT, everything will be available in the future. When it's a trauma, there will be good awareness about the golden hour, and there will also be good awareness about platinum 10 minutes that will come, and majority of the lives will be saved. And cardiac arrest, ACLS will be started everywhere when there is a need. Yes. Next, so this is about the out hospital. I have been discussing about out hospital emergency victim, how the approach is, approach is, and approach will be. That we discussed in the previous slide. Now let us discuss about in hospital. When the patient is coming to inside the hospital, how the care it is. That we will discuss now. So presently, what is the problem? Presently, the major emergency room are with emergency physicians. That means the bigger hospital, corporate hospitals are having the emergency room with them. And the triage concept is already initiated. And well-equipped, well-manned emergency rooms are there. and ACLS, ATLS, pads and also everything is there. And it is well supported by specialists. 24/7 availability is there. That is there in major hospitals. But I don't say this is there in every hospital. It has to become in every hospital. So with this present scenario, how it is happening? So when it is a polytrauma, the ATLS concepts are already in. They are putting the spine board, they are putting the cervical collar, the patients are immobilized properly, they are approaching the primary survey, the airway is being given care, ventilation is properly done, the major life threatenings are immediately addressed, and hemorrhage control is happening, and point of care facility. The ultrasound is done, and many investigations are there to the bed. It's coming to the bed. The patient no need to go anywhere. And it is there. And when it is a blood, they give only what is necessary. They don't give the entire blood. They give only what is necessary. And missed injuries are very, very less nowadays. So this is the present development of care being given to the emergency patient at the major hospital. But when you ask me, the same thing is given everywhere. It's a question. I can say 30% of the hospitals are having all these facilities. But I feel it's a good start. And when it is a acute coronary syndrome, there's a good awareness. The defibrillator, laryngoscopes, everything is available, and of course, it is experts availability is still a challenge in a small hospital. 30-bed, 40-bed hospital is a challenge. Thrombolysis is available in all major centers. Primary coronary interventions are being done by 60 to 70% of the cases, but it will be 100% in the future. When it's a stroke, good awareness of thrombolysis is there. CT and neurology is available in most of the centers, big centers, and the evidence-based approach is there. Strokes, but even having all these things, the stroke thrombolysis is low because the time taken for the family to recognize and them to approach the hospital is very less. So very more. That is the reason. Very still, though it is a ischemic stroke, though it can be reversed if they come within time, because they are coming late after 6 hours, it is a challenge. So to improve that, the government has to initiate the community awareness. As I told you before, the BLS and first aid has to be taught to the public from the classroom. Yes, when it is a cardiac arrest, inside the hospital, any patient is coming, I am sure that every hospital has got facility to initiate ACLS. So this major change had happened within this past 3-4 years. I must say a big thanks to the NABH. So when you go to the NABH accredited hospital, that means they are having full facilities. Nowadays, the private insurance and the government insurance scheme had made it mandatory to get the NABH. So most of the hospitals are getting converted into the NABH hospitals. By this way, the NABH is doing a great service to the society by having a better emergency room. When it is a poisoning, the gastric lavage supporting care is being given, and when it is a OPC poisoning, not only gastric lavage, like as it was given in the past, atropine, palm, apart from that, the lipid emulsion, charcoal hemoperfusion have been started in the few centers, but it's still not in all the centers. The scorpion sting, the tablet of prazosin and ventilator support is being given, whereas in the past, it was not given. Past, they used to give only light cocktail. And when it's a snake bite, it's not only anti-snake venom like in the past. Nowadays, the people know, the doctors know, when the anti-snake venom is not working, they are planning for the plasmapheresis and hemodialysis. And in major centers, the extracorporeal removal of poisons are also being conducted. So these are the places. There is a sign of development. There is a very good advanced care is being given nowadays. But if we say it is there only for 30% of the hospitals in the city, still 70% have to improve. I hope in the future it will improve. Okay. So what will be the approach to emergency in the future? There will be a good emergency physician, trained emergency physician in the future. Almost every hospital will have adequate emergency physician. I must thank National Medical Council for this. Almost every emergency room will be well equipped and well manned and have everything perfect in the future. Again, NMC and NABH will take forward. And every patient may have electronic medical records. Other times will change. From 20 years from now, every patient will have an electronic medical record. They don't need to carry any records with them. Maybe by simply doing iris scanning or fingerprint scanning, we can get every records they have. and there will be centralized active emergency medical service will be available. They'll be assessing and allocating the appropriate patient to the appropriate centers, and emergency care will be initiated on the wheels and ambulance itself, and the treatment to the patient will be started well before the patient is reaching to the hospital. And in the future, it is not just an emergency physician. Emergency medicine will have subspecialties like cardiac emergency physician, neuro emergency physician, gastro emergency physician, pediatric emergency physician, geriatric, interventional. So all these things, all the emergency medicine will have a subspecialty like this. So all these emergency physicians will take care of the emergencies in the appropriate centers. And it is not a surprise. Nowadays, the decompressed anatomy is being done by the neurosurgeon. Intra-arterial thrombolysis is being done by the interventional radiologist and neurologist. Emergency arterial embolization is done by the interventional radiologist. Open cardiac compression is being done only by the cardiothoracic surgeon. ECMO by cardiac team, and many of the interventions are being done by other specialties. But these things, and it's not a surprise, over 20 years of period, these things will be done in the emergency room by the emergency patient within the time and within the emergency department, which will save a lot of time. So putting it all together, the emergency medicine in future will be doing decompression, craniotomy, intra-arterial thrombolysis, emergency arterial embolization, open cardiac compression, emergency cross clamping, ECMO, and all these things would be done by the emergency patient in the emergency room. So this will be the future of emergency medicine. Thank you for the opportunity given to me, and I'm happy to answer any questions you have. Thank you very much.
Sir, thank you, sir.
Thank you, sir.
Thank you very much. The participant, can I expect any doubts? It's time to.
Any questions I can in the chat, sir, so that I can answer.
I'm Dr. Chakrarao. No doubt about his talk or anything. It's an excellent talk.
Yes, sir. Thank you,
Of course, still, of course, in India, we do not have anything. Leave alone the emergency. Even sometimes the gauze and cotton are also not available in the hospitals. That is the present state of affairs. Of course, I'm one of the persons, I'm a retired Additional Director of Health Services from Andhra Pradesh. I was the past president of the Indian Society of Anesthesiologists. For the last 4 years, we are struggling and doing something on the CPR, and we are trying to promote CPR. Probably you also will be knowing, and Dr. Radhika has told about you. And the issue is when we started to establish our own guidelines, because as you told you, we don't have the guidelines that are applied in US and Europe are not possible here, because the ambulance will not reach us within even after one hour. I am requesting the people, why don't you escort an ambulance? When you are escorting an MLA, why don't you escort an ambulance? It is very much needed. And there are a lot of places, inaccessible places in India, where even in the floods, people are not reaching. Even without the flood also, people cannot reach, the ambulance service cannot reach. And the system of ambulance actually, when it was started by Sachem, it was very good. Even now, many ambulances do not have AED. And the importance of AED is never emphasized by any of the people. Now the NMC has come and they made it mandatory by 2022. Every department of every medical college should have a department of emergency medicine. Probably they may establish, but I don't think they will have what you have seen, what I have seen in the SRMC Chennai. So the emergency is an emergency, and it should be started from outside the hospital to inside the hospital, and it should be carried throughout the journey of the ambulance. And another thing is, Actually, we with a lot of difficulty, we could influence the CBSE education system and introduced the CPR in ninth class. So now it is in their curriculum. Probably the schools are opening and closing. Probably within 6 months they will open. I think we have to train all the teachers to teach them the CPR to every school child. It is not only you are learning CPR, your family members should learn, your neighbors should learn, your relatives should learn, your friends should learn. And I have already written a letter to the authorities, the municipal authorities who are giving the permissions for the high-rise building and flats, apartments. So don't give an NOC without to any apartment without an AED. They should have their own AED. And if it is a gated community, let them have their own ambulance, equipped ambulance with everything. And these are the most important things. I don't know how many years it will take for us. We are also trying a lot. On 20th of this month, I met the Director General of Health Services. I met the Minister for the State, Central Government. We have opened, with the difficulty, we could open a training center in Safdarjung Hospital. And what I want is the training should be very easy. It should be very cost effective, because whatever we train, the paramedics, they can't afford thousands of rupees for training them. It should be very few rupees. And every medical college should have a training center, and every hospital should be guided. And the CPR, simple CPR, should be given training to all the ANMs and even the ASHA workers. That is our concept. Of course, we are moving. Definitely, probably we can do something. And thank you very much. Of course, your talk is good.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you so much for your valuable message, sir. Thank you so much, Chandrasekhar sir, for your great sharing great knowledge about basic approach of emergency patient in and out of hospital. But if participants have any queries about this talk, you can unmute yourself and ask the questions.
I think there is no questions. Thank you.
Thank you so much, sir.
Thank you, sir. Thank you, sir.
Thank you, Chakra, sir.
Thank you. Thank you.
All the next session will be start by 12 p.m.
12 p.m. Okay, thank you.
Thank you, sir.
Thank you, sir.